Hillman. He doesn't need much of an introduction. We'll get Ken to get straight into his talk. It's more interesting listening to Ken than listening to me introduce him. Thanks, Ken.
Thank you very much, Arthur. What I'd like to do is just go through how the MET system happened and to advocate unashamedly for bottom-up change as well as top-down policy. So, for example, this is top-down policy. This sign is around our hospital everywhere, saying that these are our core values: collaboration, openness, respect, empowerment. They're very good. This comes from a top-down committee of people in our local district. Doing a straw poll, no one could remember what these core values were. Everyone, I'm sure, practices them, but it's not as a result of the sign. The problem is pretty easy. Working in intensive care, you see a lot of patients who are transferred from the wards, or we used to see a lot of patients transferred from the wards who had suffered a very slow deterioration. So the problem was seen by clinicians. And what I'm suggesting here is that this problem would not have been seen by people in head office. These observations and the research behind it, which began the whole MET system, was seen by actively practicing clinicians. So designing a solution, this is a letter, and I think it was written in 1982. You could see it's written on a typewriter. So for those of you younger members of the audience, this is an instrument which has letters similar to a computer, but little things that went up and made the letters like that. And it was as a result of a 19-year-old pillion passengers, the person on the back of a bike, and her boyfriend was killed in the accident. She was admitted to an orthopaedic ward. In those days, they strung fractures up with pins and all sorts of ropes and stuff like that. And she arrested. So when I came into the intensive care the next morning, they told me that a 19-year-old patient had arrested, and I asked why, and they said, oh, probably heart attack or pulmonary embolism. And that's strange with someone just admitted to a hospital with trauma who was 19. So I went and looked at the notes, and there, sure enough, was blood pressure going down, 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 respiratory rate going up, pulse rate going up. And when the orthopaedic registrar finally got out of theatre and pulled the fracture, this person had already had large volumes of blood loss, and that was the end of it. She died as soon as they pulled the fracture. So I wrote this letter to hospital management saying that I think it would be helpful to have an early warning team instead of a cardiac arrest team. And at that time, this was in a large hospital in London, Charing Cross Hospital, of which I was the ICU director, and things moved very slowly in large teaching hospitals, and so it didn't happen. In fact, it didn't happen until much later. So developing the triggering criteria, as I said this morning in a talk, this was done by my colleague, Jill Bishop, who went into a room and 5 minutes later came out with the MET calling criteria. And for people practicing intensive care, these are fairly easy: blood pressure, pulse rate, respiratory rate, and then in case we got things wrong, empowering nursing and junior staff to call concern. And when we first started the system, 50% of our calls were for concern. But these calling criteria couldn't have been developed by policy people in head office. I keep using the word head office because I like it, but you know what I'm talking about. It's the large bureaucracy which is above the hospital bureaucracy. The response that was having someone available 24 hours a day with the skills, knowledge and experience to be able to resuscitate seriously ill people. So we just changed the cardiac arrest team into the medical emergency team. Again, there would be no one in head office who would have these skills, experience or knowledge, and they couldn't have defined it. So this system was gradually being developed by clinicians on the shop floor as a result of seeing it every day and by experience. Selling the concept to colleagues was a little bit difficult. It wasn't difficult to the surgeons because they spend all day in theatre. They loved it. We just said to them, look, if you have a sick person on the ward, we'll look after them until you get out of theatre and bring all of your expertise, which we know you've got, but we'll keep them alive until you arrive. Psychiatry, O&G, that was easy as well. Physicians was more difficult. Until we had the meeting, and the meeting was attended by a lot of angry physicians who said they didn't mind us attending after the patient had a cardiac arrest, but these were their patients and we weren't to interfere with a patient that was talking and alive. So again, Jill Bishop, my colleague, said, look, here's the deal. We're not taking these patients away from you. We know now if they have a high pulse rate, low pulse rate, etc., then they're likely to die or to have a cardiac arrest. These are your sickest people. So we know that you want to see these people. But unfortunately, you've got to be there within half an hour. And we know you've got the skills to deal with this, central lines, intubation, inotropes, etc. But it's going to be very difficult because you'll be on call 24 hours a day, 7 days a week, no dinner parties, no alcohol. But we know that you're very interested in owning these people. You could just see the faces changing. You know, they were worried, looking around like this. And then they reluctantly agreed to let Jill Bishop institute this trial, but only for 3 months, and then we'll see how it goes. And of course, it kept going. The movement begins. The movement, again, was bottom-up, led by clinicians. People like Ronaldo Bellomo from the Austin Hospital here, Julian Bion from the United Kingdom, Mike DeVita from Pittsburgh, and people from Scandinavia and Germany as well. These were people who shared our concern about the fact that a lot of deteriorating patients weren't doing so well. And so there was this sort of like a Mexican wave. You know, there's a few people put their hands up, and then there's a few more in the seats next to them, and then gradually it went around the whole stadium. And so it was as a result of research and publications, again, by clinicians working from the bottom up. It was part of conferences. There were a few sessions which were devoted to rapid response system. And then Mike DeVita and myself set up the first international conference on rapid response systems in Pittsburgh, more publications, more conference presentations. But more than all of that, it was discussion in the corridors about this. We'd phone each other, we'd email each other, and there was this impetus beginning. So where is head office in all of this? It took 10 years before we engaged head office, and that wasn't because we didn't try. Myself and other colleagues went to state departments of health, local area health districts, and federal departments of health. Similar problems were being found in Scandinavia and the United Kingdom. In fact, it was the IHI in the United States who were the first people to take it up. And then Denmark was the second one, where one of the intensive care physicians had a husband who was a senior administrator in the health department. But they didn't want to know about us because we were clinicians coming from the bottom up. And I'm sure a lot of clinicians knock on these people's door with weird ideas and maybe some good ideas as well. And then there was an incident where a girl was hit by a golf ball, and she slowly died in a Sydney teaching hospital. At the same time, there was a SARS epidemic in Ontario and Canada. But the girl who died slowly with the golf ball, that resulted in a wide-ranging look at the way hospitals operate. The person in charge of that investigation was called Garling, and I'd actually worked with Garling. He was a QC, and I worked with him, as a witness in one of the court cases. And so he came out to talk to me, and I told him about the MET system. He thought it was a good idea, and so in his report he said that every hospital in New South Wales should have this system. So things began to happen. And the New South Wales government gave the job of implementing the MET system to the CEC, and they did a superb job. So the first thing they did was get physicians who were interested in this area, who had had experience in this area, meeting with senior administration. And we all sat in a room, and of course there were disagreements about calling criteria and this and that, but the concept was generally very well accepted. So after several years of work, we implemented the between the flag system across every single hospital in New South Wales. If I could just get a bigger picture here, the patient safety industry started in the early 1990s, and it was published by lawyers who were being sued for potentially preventable deaths, and they were published in the New England Journal of Medicine. This was the beginning of let's look at patient safety in acute hospitals. Ever since then, there's been a lot of attempts to improve patient safety, and I'm sure we have improved patient safety, but it's never been proven. So there's a large patient safety industry with its own journals and textbooks and meetings, and we extrapolate from other industries such as the aircraft industry and the mining industry, all sorts of policies. There's accreditation, but none of these efforts, none of these interventions have ever been proven to improve patient outcome. They probably do, but it's never been proven on a large scale. There's also a lot of language used by the patient safety industry, such as accomplishing collective goals, creating binding cultures, words like networking, stakeholders, daily huddles. And there's even a book written by the man that ran Disneyland, who then became the CEO of a large hospital. And he said, I know how to do this because I ran Disneyland. And so there's all sorts of people who've been involved in patient safety, but again, no evidence that any intervention has worked. And there's been 2 very large studies on top-down patient safety studies, one in the United Kingdom and one in the US. Again, it was very rigorously done, but with no hard evidence, which doesn't mean that it doesn't, that it didn't work, but no evidence. So turning policy into practice. I like this study from Sweden. It was as a result of 3 end-of-life policies that were handed down by the national government, one by the state government or its equivalent, and one by the local health authorities. And when they asked people who worked in the shop floor, managers and clinicians, had they ever heard of it, only 2% had read these policies. And I think that's one of the issues, that there's a disengagement between policy and implementation. Now in Sweden, policies must be accompanied by an implementation strategy, right down to how it's going to work and what are the outcomes, and the outcomes are measured, and you are judged not by the policy documents you produce, but by whether it's influenced patient safety or patient outcomes at all. Stefan Zweig, even from the middle of the 19th century, said it was easier to write 10 volumes of philosophy than to put one principle into practice. So next step, I'd like to see the same entrepreneurial spirit that we have in people that produce fancy equipment to improve patient outcomes. I'd like to see that same entrepreneurial spirit being encouraged in healthcare, and it is in some countries at the moment. I'd like to see health funders and clinicians developing new relationships and embracing unique and new ways. And I think Harvey Lander talked this morning about Professor Darcy, I think it was, who said we need to unlock the talent from the shop floor in our health system and create health systems laboratories to experiment with different ways of developing and evaluating patient safety systems, or ways to improve patient safety. But above all, we must be linking policy and implementation. Thank you.